So moving on to question number 47. This is an image-based question. There is nothing in the text here to give you any hint, any iota of help. Look at the image, identify, tell me what is causing it, right? We know for sure it's a deficiency, but the deficiency of which of these micronutrients is causing this particular clinical picture. Look at this. Where do I go? Yes, I go like this. Now, look at the image here. This is the image of a baby. Yes, whoopee, that's 100 points for this. I identify that this is a baby. Beyond that, what does it show you? Beyond that, it shows you that there is some erosion. Like, yes, there is some erosion, crusting. I'll write it like this, 0.1, 0.2, 0.3. So what do you see? First point is erosions. Second point is you see this crusting. Third point is there is some scaling, and it is in a perioral distribution. Then the eyes are covered, otherwise it is also in the periorbital distribution. That is the clinical picture. So erosion, crusting, scaling in the periorbital area. Had I seen this baby completely, I would have seen that this kind of picture is also present in the perianal and the perineal region. The legs, what do you think it is? I know you all know the answer. This is a relatively easy one. Zinc. Zinc deficiency is what causes this picture. I'll tell you what it is. This is acrodermatitis enteropathica. Acrodermatitis enteropathica. This is an autosomal recessive inherited disorder. There is a defect in zinc transporter in the GI mucosa, due to which there is a zinc deficiency. Manifest in babies during weaning. See, breast milk is very high in zinc, and the zinc there is easily absorbable. So when the baby is exclusively breastfed, he or she will not manifest the symptoms of zinc deficiency. Okay, it is only when you start weaning the breast milk, zinc absorption decreases, baby starts to manifest the symptoms of zinc deficiency. So these will generally come at around 6 months of age or later. In acute type of presentation, you will have vesicles, erosions, which will be crusted in the acral areas, as the name suggests, acrodermatitis, which means perioral, perianal, perineal, and hands and feet. So this will be the typical picture. Generally in the clinical setting, the patient might have had an episode of diarrhea. When there is an episode of diarrhea, there is further reduction in the absorption of zinc. Even more symptoms of zinc deficiency manifest. So the baby may have had these symptoms after an episode of diarrhea, or he may be having diarrhea during that time also. This is how the picture will come. Supposedly it's a chronic picture. In chronic it will be like it has been going on for a longer time, then it will be erythematous, scaly plaques in similar distribution. Important. All these points are important. They are all asked. Acrodermatitis enteropathica. Clear? Clear to everyone? Yes. Now, how do you diagnose? You diagnose clinical picture. Then serum zinc, it's a very difficult and expensive examination, so sometimes you can also measure the level of serum ALP, because ALP is a zinc enzyme. The zinc plays an important role in ALP. Measure the levels of ALP. If zinc is less, ALP is less, and vice versa. So you can also measure levels of serum ALP. How you treat? You treat high dose of zinc, around 2 to 3 mg per kg per day. So this is how you treat acrodermatitis enteropathica. Clear to everyone? Remember the inheritance, the typical clinical features, and the treatment. Even the dose is asked. ALP is asked. So these are all important points, right? What is the other option? What does niacin deficiency cause? Niacin deficiency causes pellagra, the 3 Ds, the diarrhea, the dementia, and dermatitis. Photosensitive distribution. In photosensitive distribution, then you have the Castle necklace, you have the gauntlet sign. This is pellagra. Iron deficiency causes anemia and koilonychia. Selenium, non-specific, nothing major. Zinc, acrodermatitis enteropathica. Clear to everyone? Yes, I have given you the major things of all the other things, all the other options, and this image is that of acrodermatitis enteropathica. Moving on to the next question. The next question is 48. Long question, read it. We will discuss it after that. This is actually a repeat. You have read this already. It's a male who is 50 years old. Single flesh colored lesion on the forehead, no other symptoms, dome shaped. I am sure this gives you a hint to what the diagnosis is, right? This is giving you a hint already. We have already gone through this. Histopathology is given to you. Clinical image is given to you. I will move this way, right? Histopathology is given to you. Clinical image is given to you. Description is given to you. What else do you want? It's a clear-cut question. Clear-cut diagnosis. We have already discussed it. Tell me fast what it is. Look at the image. Look at the histopath. Does it look like the image of molluscum contagiosum? We saw it. We saw the histopath also. Does it look like that? No. Does it look like squamous cell carcinoma? Clinical image is not like that of SCC. No. Does it look like BCC? Again, no. The central keratin filled crater is in itself a hint enough. This is in itself a hint enough. Even if the clinical image was not given to you, this tells you that this is keratoacanthoma, right? This gives you the hint that this is keratoacanthoma. And then you look at the histopath here, you see that the center is full of this pinkish colored keratin. It's a nodular shape. If you see it in high power, you will see dyskeratosis also, mitosis, feature suggestive of disarray, like a pre-malignant lesion you will see. What was the molluscum histopath? Molluscum was like this. There were these bands which were coming, right? This was molluscum histopath. Here you don't see that. Here you see very irregular structure. Very irregular structure. Does not look like molluscum. Please don't confuse. Look at the image. Read the text. Come to the diagnosis. Answer here is Keratoacanthoma. A relatively simple one because we've just read Ka. Even if it was a de novo first question, enough to give you a hint of the diagnosis. Right? Good. Moving on to the next question. A child came with small papular lesions, elbow, penis, forearm, pinhead, discrete. What is the diagnosis? Yes, tell me. It's a good question. You know it, you know it. Tell me. What do you see in the image here? Look at the image. What do you see? Multiple skin colored papules on the extensor aspect. Then look at this here, shows evidence of Koebnerization. It is in a small child. Penis is also involved. What is the diagnosis? Lichen planus, scabies, phrenoderma, lichen nitidus. We will discuss all of them together, only then will you know. First, see lichen planus. 5 P's you should know. Purple pruritic polygonal papules. So these will be purple, itchy papules, mainly on the flexures. Then lichen nitidus. These will be flat-topped, pinhead size, skin-colored papules, mostly on the extensors, and in men on the penile shaft. Phrenoderma will be multiple follicular papules on a background of xerosis on extensor aspect of joints. So this is how these 3 will look like, and this will be non-itchy, this will be mildly itchy, this will be very itchy. Clear? Very itchy, mildly itchy, non-itchy, flexure, extensors, and this is only around the joint extensor. So clear to everyone? Good enough? Good enough? Now, scabies, I'm not discussing scabies, we've already done it. So out of these 3 options, what is the one that is there in the question there? Come back to the question. Here, these are papules on the extensors, skin colored, itching is not mentioned. Lichen nitidus. Clear? Any doubt? Koebnerization can be seen in lichen nitidus, in lichen planus, vitiligo, psoriasis, lichen scabies, you know, will be seen more in the circle of Hebra distribution. Phrenoderma would only have been on the joint, not on the forearm or the penile shaft. Phrenoderma is due to vitamin A deficiency. This is a manifestation of vitamin A deficiency. Okay? Moving on to the next question. Read this question, see the image, tell me the answer. What does this image tell you? What does this image tell you? This is an elderly man. You see wrinkles here. He has these erythematous plaques on the back, on the scalp, everywhere on the body. Then this one shows some ulceration also. Not that easy to make a diagnosis here just looking at the image. It could look like any eczema, it could look like even psoriasis from a distance. So it's not that easy for you to make out the diagnosis from the image itself. The hint in the question to make out that is that look at the options here: electron beam therapy, fluorouracil, radiotherapy, chemoradiation. That means that the question is talking about some malignancy. Image may not be clear, but the options give you a hint that it is a skin tumor. Now, coming to the skin tumor, what are the skin tumors that you know about? We know that there is something which is SCC, something which is BCC, then a malignant melanoma, then mycosis fungoides or CTCL. These are the main skin tumors that I know about. Does this look like SCC? Does it have an ulcer or a nodule? No. BCC is again a papule or a plaque with rolled up margins. Does it look like that? No. Malignant melanoma is a melanocytic tumor. It will be black in color. No. Eczematous lesions are seen in mycosis fungoides. So the diagnosis that I reach here is mycosis fungoides. Trust me, just seeing the image, it will be very difficult for you to diagnose. Taking the hint from the question that it's a malignancy, ruling out different skin malignancies, coming to a diagnosis of mycosis fungoides because there you have these typical lesions. You know image MF. Now let us look at the treatment. What is the best treatment? In mycosis fungoides, remember that there are 3 stages: patch, plaque and tumor. Patch, plaque. Generally the tumor stage also has systemic involvement. So patch will be a flat lesion, plaque will be a raised lesion, tumor will be nodules which have depth plus systemic involvement of other lymphoid organs. So in the patch, the treatments that you generally do are topical chemotherapy drugs. Then you can do phototherapy like PUVA. In the plaque stage, best treatment is electron beam therapy. In tumor stage, you give chemotherapy, you give radiotherapy. There is no role of surgical excision. How much can you excise surgically? You cannot. There is no role of surgical excision in widespread lesions like the ones which are shown in the image there. And remember that all these treatments are palliative. None can cure the disease. It is ultimately fatal. Ultimately fatal. None of these treatments can completely cure it, but you should still remember as per the stage. If the question asks you treatment as per the stage, you know it. If it asks you which is the best treatment, irrespective of the stage, this is the best treatment. Skin electron beam therapy is the best treatment. Okay, if it specifically will ask you in the tumor stage which is the best form of treatment, then yes, chemotherapy and radiotherapy. If there is no stage mentioned and just treatment is asked, best is electron beam therapy. Okay, and it is an ultimately fatal disease. All treatments are palliative. One more thing you should remember with MF is Pityriasis abscesses. These are lymphocytic abscesses in the epidermis. Then another thing that you should remember with it is Sézary syndrome. This is the last stage. This is a triad of erythroderma, lymphadenopathy, and Sézary cells more than 1000 per cubic mm. So absolute number of Sézary cells is high, there is multiple lymph node enlargement, the entire skin is red. These cells are T cells with a cerebriform nucleus. This is the last stage, the final stage. So Sézary syndrome remember, Pityriasis abscesses remember the treatment. That's all that you need to know about mycosis fungoides. Clear? Good. Moving on to the next question. Question number 51. What does question number 51 talk about? Talks about a 23-year-old female presented with pruritus, genital discharge, cervical smear findings are given to you. Identify the diagnosis. Tell me what the diagnosis is. What is the diagnosis here? What does the image tell you? Can you see this in the image? This particular cell in the image? Look at this cell, and this cell. Look at these. What does it show you? This is a normal vaginal squamous cell. This one is normal. Look at this cell. What does this cell look like? This cell looks like this. Small blackish structures are very attached to it. So what is this? Looking at this image, tell me the diagnosis. It is a clue cell. What is a clue cell? Clue cell is vaginal squamous cell studded with Gardnerella. That is what a clue cell is. So this image tells you that it's a female with discharge and itching. This is actually wrong. It should be a vaginal smear. The vaginal smear shows clue cells. What is the diagnosis? You know what the diagnosis is. Tell me the diagnosis. The diagnosis is bacterial vaginosis. What is bacterial vaginosis? Tell me. This is the most common cause of altered vaginal discharge in women of reproductive age, means in sexually active women. This is just an altered vaginal flora. Lactobacilli decrease and other Gardnerella, Prevotella, Mycoplasma hominis, these increase, right? This is not a STI. Clinical feature will be foul smelling, watery discharge associated with itching. What will this smear show? Smear will show clue cells more than 20%. Because these are commensals, these organisms are commensals. They are living normally in the vaginal tract. In case of bacterial vaginosis, what happens is that their number increases, lactobacilli decreases. So clue cells which were normally present also, because these organisms are normally there, will now suddenly increase in number. Around 5-10% clue cells will be found in even normal vaginal smear. But in that of a bacterial vaginosis, the percentage will be more than 20%. So this smear, it will be more than 20% of clue cells. And since lactobacilli decrease, acid decreases, pH increases. So the pH becomes alkaline. Clear to everyone? Clear? Have you all got it? So I have this table of the diagnostic criteria. In order to make a diagnosis of bacterial vaginosis, we have these criteria. These criteria are called as AMSIL criteria. You need 3 out of 4 to make a diagnosis. Typical discharge, whiff test is important. It is asked. Fishy odor when 10% KOH is added to the secretion. Clue cell more than 20%, alkaline, pH. These are all the criteria. They are asked in all except or false. Very, very important. Please remember, they will give you all of these are features of bacterial vaginosis except 1, 2, 3, 4. pH less than 4.5. pH is alkaline, more than 4.5, because lactic acid, glycogen breakdown, that also produces acid, that is all decreased. pH is alkaline. Please remember these all things, very, very important. AMSIL criteria. Clear? Then this is an image of the clue cell. This is how a clue cell looks like. It's a vaginal squamous cell studded with these bacilli, the Gardnerella bacilli. This is how it looks like. In that image also, there, these cells are the clue cells. I am just showing you a color photograph which is enlarged. So identify the fact that these are clue cells. Then how do you treat? Treatment of choice is oral metronidazole. This is the treatment of choice. This is the second line agent. Since this is not an STI, you don't treat male partners, but in case of a female partner, you should treat, because then these bacilli can transmit between the females. From male to female, it doesn't go, so no need to treat the male partner. Treatment of choice, oral metronidazole. However, the problem with bacterial vaginosis is it can be recurrent. In some questions, it can be given as a recurrent genital discharge. So recurrent infection is a BV, bacterial vaginosis. Clear to everyone? What does Klebsiella granulomatosis cause? Klebsiella granulomatosis causes donovenosis. That is a cause of genital ulcer, not discharge. Gardnerella, I told you, causes bacterial vaginosis. Trichomonas causes a greenish frothy discharge with strawberry cervix. Chlamydia causes a mucoid discharge from the cervicitis that it causes. Answer here is Gardnerella. Clear to you? Yes. Moving on to question number 52. In question number 52, read this question. What does it talk about? It talks about a young male who presented with a hypoanesthetic patch, thickened nerve. Wow. You know, the description in the test is pretty simple, pretty easy. We have just gone through a similar question in leprosy. But if you look at the histopath is not that clear. It is not an image which is telling you what it should. So you can, ignore this image. It is not giving you the right field. Just go through this and you should know what the histopath will show. We had just discussed in the previous question that a tuberculoid plaque is the one which is hypoaesthetic and it has a thickened nerve. HPE will show very defined granulomas. In this one you see that yes, there is a granuloma here, but you cannot make out exactly from the image. So ignore the histopath here. Look at the options. LL leprosy is not hypoaesthetic patch, a single patch. No, it will be more widespread lesions with multiple thickened nerves. Lymphoma, again no. Histiocytosis, again no. The answer is TT leprosy. Clear to everyone? Yes. Nothing major in it. We have already discussed tuberculoid leprosy. Moving on to the next question. What is it talking about? So this is a 20-year-old patient, neurocysticercosis, peeling of skin after taking medication for seizures. What is the most important, or what is the diagnosis here? 20-year-old patient, neurocysticercosis, peeling of skin 1 month after starting with medication for seizure. We definitely know that it is a patient who has taken anti-epileptics. Now he has developed a skin rash. Diagnosis. What do you see in the image here? The image tells you that there is peeling of skin, right? This thing here, number 1 here, see this here, number 1, and you see these number 2 lesions. So what does it tell you? In number 1 it is peeling, in number 2 there are these widespread purpuric lesions. There is absolutely no doubt in diagnosis. It is toxic epidermal necrolysis. It is a drug rash that the question is talking about. The image shows peeling of skin in sheets with widespread necrosis which looks purple, purple, purple. These purpuric lesions are actually necrotic skin. Diagnosis, toxic epidermal necrolysis. When you have the drug rash, then it is SJS, SJS 10 complex and 10. This is less than 10% BSA. This is 10 to 30% BSA, and this is more than 30% BSA. Here you see more of targetoid lesions with mucosal involvement. Here you see more of peeling because the necrosis is so widespread, plus mucosa, plus skin tenderness. Wherever you touch on the skin, the patient has pain. Histopath is full thickness keratinocyte necrosis. The entire epidermis is necrosed. Scoring of severity is through Scotton scoring. Treatment, stop the drug. Symptomatic management, there is some role of steroids, cyclosporin or IVIG, right? This is all that you need to know about SJS 10. Then you need to know that the most common drugs are antibiotics and anti-epileptics. Most of the question will talk either about antibiotic or anti-epileptic. Clear to everyone? Now you know about SJS and 10 is clear. Severe mucosal involvement, hemorrhagic crusting on the lips, peeling of the skin, all of these are typical of SJS and 10. Clear? So if you go to that image, see the image again, that the patient develops this peeling of skin 1 month after treatment for seizures. Answer, toxic epidermal necrolysis. Clear? Good. Question number 54. The condition seen in the illustration is. What is the illustration? Again, a totally question based on image. See what the image is telling you. What is the image telling you? Nose is involved. There is a skin colored fleshy potato-like tumor on the nose. What is this? Very, very typical image, and a very important question asked very commonly. What is this? Diagnosis. Tell me what the diagnosis is. Diagnosis is Rhinophyma. I know most of you know it. This is a Rhinophyma, which is seen in long-standing cases of glandular rosacea. In long-standing glandular rosacea. Clear to everyone? This is Rhinophyma. Any doubts? No. No? Good. If you see it clearly, you will also see a lot of surface telangiectasias on the surface, typical of rosacea. Next question. Again a long one, image is given along with it. Read it, tell me what it is. Sexually active male, vesiculobullous lesion on the glands after taking a paracetamol tablet, healed with hyperpigmentation. Simple one, very simple. Yes, they are giving you some twist in the question to confuse you, but it is otherwise a very, very simple question. We know that this has happened after taking a drug. So this is a drug rash. Heals with pigmentation. Has come on the glands. What is the diagnosis? Fixed drug eruption. Behçet's will be more of an ulcer which will be recurrent. Herpes will be erosion, painful. Pemphigus vulgaris though different picture. Clincher is hyperpigmentation. Clincher is this point, this one. This actually gives you the hint that it is FDE. FDE. This is what you need to remember about FD and the fact that it has interface dermatitis in histopath. Most common site is perioral on the face. Please remember all these points are very important. Same site every time. The patient will give you a history that every time I have this medicine, I have a rash which comes at the same site. It comes at the same site, and it will be an erythematous plaque with central bulla, heals with hyperpigmentation. Most important point. This will tell you what the diagnosis is. Drugs, NSAIDs. Last year in AIMS it was asked in association with NSAIDs. FDE. Clear? Behcet's, I told you, is more of an ulceration. This will be painful erosions. Very different. Answer is this. Moving on to the next question. Read it. Tell me what it is. A patient of acne treated with tetracycline, papulopustular lesions around the nose and the lips. What is the diagnosis? Tell me. Simple one if you know it. Simple one if you know it. If a patient of acne is on long-term broad-spectrum antibiotic like tetracycline, what happens is gram-positive bacteria decrease, gram-negative bacteria increase. This causes folliculitis by gram-negative bacteria. So, the answer here is gram-negative folliculitis. This is the result of giving long-term unregulated antibiotics for acne. Gram-negative folliculitis caused generally by gram-negative organisms like Escherichia, Klebsiella. Okay, Escherichia, Klebsiella, or Proteus mirabilis. Okay, so this is the most common cause. Now you again treat them with their specific antibiotics. Gram-negative folliculitis. Typical location is around the mouth and the nose, while acne lesions are present elsewhere on the skin. So this is gram-negative folliculitis. What is Morbihan's disease? This is seen in long-standing rosacea. There is woody hard edema on the face. Chloracne is acneiform lesions as a side effect of exposure to iodides and bromides seen in factory workers who are exposed to these fumes. Rosacea we have already discussed. It looks completely different. It will also have papules and pustules, but there will be a background of erythema, atrophy, telangiectasia. Morbihan's disease will be edema of the entire face. So this is the other option. Best answer here is gram-negative folliculitis due to long-term exposure to a broad-spectrum antibiotic. Clear to everyone? We move on to the next question. Wow, a pretty long one. Read this and tell me what the answer is. Let's read it together. 1 week history, itching, discharge without the use of a condom. Vulva is edematous. Smear shows flagellate protozoa. You prescribe an antibiotic. What warning do you give the patient about the treatment? Pretty long one. You have to make the diagnosis, you have to know what treatment is given, and you also need to know the side effect of that drug so that you can give appropriate precautions to the patient. Tell me what it is. You cannot make out anything from the discharge. There is nothing particular about the discharge. There is no description of the discharge. It is just said that the discharge is present on the vaginal wall. So how do you make the diagnosis? You make the diagnosis from one, smear, two, image. Smear shows flagellate protozoa. Image shows red dot 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 on the cervix. What does this look like? This looks like strawberry cervix, right? So a flagellate protozoa with strawberry cervix. Tell me the diagnosis. In a female who has had unprotected sexual intercourse, what will be the diagnosis? Fast, give me the diagnosis. Diagnosis is Trichomonas, the organism being Trichomonas vaginalis, which is visible as a flagellate protozoa in the wet smear made from the vaginal discharge. Treatment of choice? Treatment of choice is metronidazole. Treatment of choice is metronidazole. What is the interaction with metronidazole that you need to aware of? Disulfiram like reaction. So a disulfiram reaction, when does that happen? A disulfiram like reaction with metronidazole happens when the patient takes alcohol. So what do you have to tell the patient? When you give metronidazole, you have to tell the patient that he or she has to avoid alcohol. So in this question, they are testing everything. They are testing your microbiology, your dermatology, your pharmacology. They are asking you to make the diagnosis, know the treatment, know the side effect, know the precaution. So the side effect is the disulfiram-like reaction seen when you take alcohol with metronidazole within 48 hours of the dose. A good question, I will say, but an easy one nevertheless. Pretty easy. Flagellate protozoa and strawberry cervix leave you no doubt that the diagnosis is a trichomoniasis. And the typical discharge, I told you, if at all you are even asked in the question, the typical discharge is the greenish frothy discharge, and this is an STI. You also have to treat the male partner also. So this is a STI. Treat the male as well as the female in this particular STI. Should we move forward? Yes. Tell me what this is. What is this? What does this image tell you? Image tells you that they are talking about a lesion on the plantar aspect which has a hyperkeratotic base, and the surface shows you brown stippling. Surface shows you brown stippling. This is a lesion on the base of the foot on the plantar aspect. The diagnosis is a plantar wart. Diagnosis is a plantar wart. Deep are the ones which are called as myrmecia. They are painful. Superficial are called as the mosaic warts. These are relatively less painful. This is caused by HPV-1. This is caused by HPV-2. Like this is in the feet. This is the wart. Remember that 1 comes deep, 2 comes superficial. This is MY. MY is in the last. It is deep. MO will come first. This is superficial. So a deep plantar wart is myrmecia wart caused by HPV-1. It is very painful, while that which is superficial is caused by HPV-2. Clear to everyone? Then in the verruca vulgaris, which is the common wart found on rest of the body, there the most common causes are 2 and 4 types of HPV. In planar warts, which are your verruca plana, there it is HPV 3 and 10. Then in the genital warts, it is 6 and 11 commonly, 16, 18 are less common. Clear? So these are the different types of wart that you should know, and their subtypes, important questions. There is another thing which is called as epidermal dysplasia verruciformis. There it is HPV 5 and 8. So please remember, all of these are pretty important questions. Subtypes you should know. This is generally asked, this is asked, this is asked. So please remember these. What does the question here say? Filiform warts. Filiform is just a morphological description of warts which are finger-like. Means they will look like this. Filiform warts. EDV is a genetic defect, autosomal recessive inheritance. There is increased predisposition to HPV infections caused by 5 and 8. Verruca vulgaris is the common wart found elsewhere on the body, 2 and 4. Right? We are done with this. Moving on to the next question. Question number 59. Female with given lesions as shown in the image, present since birth, spreading over months and years. What is the diagnosis? What is the diagnosis? Tell me. Since birth. See the image here. In the image, what do you see? You see multiple skin colored, 2 erythematous papules and plaques present in a linear pattern along the blastocoid distribution. So blastocoid distribution, linear pattern, importantly present since birth. If it is present since birth, it has to be a nevus, right? Looking at the image, if you can tell me the diagnosis, excellent. Otherwise, we will rule out. You all know that lichen planus is an acquired thing. It comes after birth. This is not present since birth. Not the answer. Becker's nevus is a nevus, but this comes at puberty. Again, not the answer, and it is black in color. Congenital melanocytic nevus, yes, present since birth. but it is black in color. The answer here is inflammatory linear verrucous epidermal nevus. Congenital melanocytic nevus present since birth, but black in color with thick hair in it. Lichen planus will be purple papules. That is actually the most important differential in this case, because here the lesions look like a lichen planus, they are slightly purplish, but that is not present since birth. Not the answer. Becker's nevus is also not present since birth. That is an androgen sensitive nevus, comes after you attain puberty. There will be blackish pigmentation with overlying dark black hair. Not Becker's nevus again. Answer is ILVEN. Inflammatory linear verrucous epidermal nevus. Look at the image again. This is how ILVEN looks like. Clear to everyone? Any doubts in this? I hope not. So we move on to the next question. Question number 60. What does question number 60 ask you? What is this sign showing? Look at the image and tell me what is this sign. What is this sign? This is a photograph in which there is some lesions somewhere on the body, but there is a predominant distribution along the waistline where you generally tie your trousers or the salwars in the females. So there is lesion at the site of trauma where the skin is having the elastic of the trouser. So what is the sign called as? Appearance of lesions at site of trauma. This is called as Koebnerization. We already discussed it in a question before, right? We have already discussed it, but I will tell you in short once again what is Koebnerization. This is an all or none phenomena. If it will be there, it will be present at all sites, or it will not be there. There will be new lesions at site of trauma appearing 7 to 14 days after it, seen in psoriasis, vitiligo, lichen planus, lichen nitidus, sometimes in erythema multiforme also. So these are all the causes of Koebnerization, new lesions happening at the site of trauma. Then there is something which is called as pseudo Koebnerization. Pseudo Koebnerization, what you see? You see this in infectious disorders which spread by surface inoculation through trauma, seen mainly in the viral infections like warts and molluscum contagiosum. So you get a question on pseudo Koebnerization also. What actually happens is you have one viral lesion and you scratch on it abrade the skin further, the small viral particles inoculate there, cause a new lesion. So that is called as pseudo Koebnerization, seen in molluscum and viral warts. Clear? So you know this, and now you know all the questions related to Koebnerization. So we come back to the question here. This is an image which shows Koebnerization. We know that it is seen in psoriasis and lichen planus and vitiligo, but it is not seen in Pityriasis rubra pilaris. Exactly what the question is asking her. Koebnerization is seen in all except, it's a good question. It is asking you to identify Koebnerization from the image itself. So we move on to the next one. Again a very good question. Tell me the answer to this. In the figure given below, which virus is associated? HHV 7, 8, CMV, BVB. You will tell it only after you tell me the diagnosis. So, tell me the diagnosis. What does the image show? Shows you multiple erythematous plaques on the back. See one thing, they are present like this. What is this pattern here? This is the Christmas tree pattern. Can you now tell me the diagnosis? Can you now tell me the diagnosis, yes or no? Tell me. For that we will read this. The diagnosis is Pityriasis rosea. This is a disorder which is mostly idiopathic, but sometimes it can be associated with infections, sometimes it can be associated with drugs. The infection with which it is associated is HHV 6 and 7. Drugs are your ACE inhibitors, crisofulvin and metronidazole. What is the typical clinical feature? Typical clinical feature is that first you have a herald patch. This is a single lesion which comes on the trunk. One to 2 weeks later, you have multiple lesions which again come on the trunk in the Christmas tree pattern, right? Multiple lesions which come on the trunk in the Christmas tree pattern. That is herald patch followed by this. Now how does a typical lesion look like? Typical lesion looks like an erythematous annular plaque with central clearing and peripheral scaling. So what do you need to know? You need to know idiopathic, you need to know HHV 6, 7, then the drugs, then the herald patch, then the Christmas tree pattern, then the typical lesion with peripheral collarette of scaling, which then come along the lines of cleavage in a Christmas tree pattern. What is the treatment? Treatment is self-limiting. It resolves on its own, self-limiting. If at all you have to treat it, then you give either emollients, which means moisturizers, or sometimes you could give topical steroids. Clear? So that is the treatment. Emollients, topical steroids, erythematous annular plaque, Christmas tree pattern, herald patch, everything that you need to know about Pityriasis rosea. Clear? So in this question, we come to the diagnosis that this is the typical Christmas tree pattern, Pityriasis rosea, cause HHV 6-7, answer is A. Good? Good. What is HHV 8 associated with? HHV 8 is associated with Kaposi sarcoma. What is CMV associated with? CMV is associated with salt and pepper retinitis and other features in immunocompromised people. What is EBV associated with? Infectious mononucleosis, then oral hairy leukoplakia, then ampicillin rash. Important. EBV is associated with IM, oral hairy leukoplakia and ampicillin rash. Clear to everyone? Good. We move on to the next question. What does this show you? What does this show you? In the figure, disease shown is a disease of, what is this figure? What do you see here? Concentrate on this area. It is much more clearer. Tell me what this shows. What does this show? You see multiple pinpoint yellow papules on the oral mucosa. You can also see them on the lips, not in this image, but otherwise, what is the diagnosis? See here, in this, here you're able to see this on the lips also. What is the diagnosis? Yes, 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 very good. Very good. What is the diagnosis? The diagnosis is for dicey spots. The diagnosis is for dicey spots. Very typical image. Very, very, very important question. I can tell you it is asked every alternate year. Something or the other on the apocrine, eccrine or this sebaceous gland, they will ask you. They are too obsessed with this. Obsessed with vesiculobulus, obsessed with scabies pediculosis, obsessed with these appendages. What is the diagnosis? For dicey spots. Now what are for dicey spots? For dicey spots are ectopic, sebaceous glands. This is a normal finding. It is not a disease. It's a normal finding. It's not a disease. This is an ectopic sebaceous gland. Clear to everyone? Had this been an image of the lips like this and it would have these yellow dots, then also it would have been for dicey spot only. Here it's a slightly tricky one because it is giving you the image of the buccal mucosa. That is something you are not that used to seeing for dicey spot. But the answer here is that only. Clear to everyone? Yes. So moving on to the next question. एक मिनट. अब काट देना बीच में. वो दे दो कॉफी. कौन से सर को?
कुलदीप सर को मेरे को डांटा निकल आते हैं।
क्या एडिटिंग
होने वाली है इसमें?
क्यों?
बीच में रुका है, आप रुके। अब ये जो आप बोल रहे हो ये भी
तो कर दो ना।
तो मैं ऐसे थोड़ी ना होती है, बैठना पड़ता है उसके लिए, हम पूरी वीडियो सुननी पड़ेगी उसके लिए।
अच्छा तो फिर एक काम करो, वो टाइम नोट डाउन कर लो जिस टाइम पे एडिट करना है, फिर पूरी नहीं सुननी पड़ेगी, टाइम नोट डाउन कर लो। चलो, so this is for dicey spot. Moving on to the next question. Next question is this one. Question number 63. What does this tell you? Question number 63. What does this tell you? This tells you that there are ulcers on the chest wall and the axilla associated with underlying sinus tract and discharge. What is the diagnosis? Tell me the diagnosis. Tell me the diagnosis. Look at the image here. What do you see in the image here? Not very clear, but what you are looking in the image is an ulcer with bluish margins present in the axilla and the chest, and as per it, it also has discharge and sinus tract. Very, very typical. If something has a bluish margin, then it is without doubt a tubercular ulcer. And tubercular ulcer, most common cause is scaphoderma. This is the most common cause of a tubercular ulcer, scaphoderma. Lupus vulgaris is more of a plaque. It is more of a plaque which is fleshy, which has central scarring and an active serpiginous edge, right? So this is how lupus vulgaris looks like. Scaphoderma, exactly how it is mentioned here, along with the fact that this is adherent to the underlying structure from which it is arising. Scaphosorum are multiple pinpoint papules present in a grouped pattern on the trunk, mostly in children, and this is a type 4 HS to the primary infection. What is TBVC? TBVC is warty tuberculosis, completely different. What is TBVC? TBVC is warty TB, present generally on the trauma prone sites. This is all that you need to remember about this. Another fact, that scaphoderma, most common site is the cervical lymph node, which means neck, and it is most common form of TB in children in India, and it is AFB positive plus. There will be copious amount of AFB in the discharge, right? Lupus vulgaris, is the most common form in adults. Clear to everyone? Yes, no. So most common tubercular ulcer, most common cause of tuberculosis in children, scrophulodoma. Most common tuberculosis of the skin in adult, lupus vulgaris. Most common site, it actually is a form of contiguous spread of the infection from the underlying structure. So this is like a lymph node here. This lymph node is full of TB bacilli. It will form a cold abscess here, and then one day it will break out, leading to discharge of pus. So this is like a contiguous spread of infection from the underlying structure. It will be adherent, can be there from a bone, a joint, a lymph node, wherever there is tubercular infection. Moving on to the next question. Question number 64. Here this is a 42-year-old male, complains of itching. Clinical presentation is shown. Which of the following is false? Look at the image, tell me what the image tells you. Tell me what the image tells you. The image tells you that it is a ring shaped, that means annular plaque with central clearing. That is all that you can make out in the image here. The question tells you that there is itching. Enough for you to come to a diagnosis. Which of the following statement is false? Before that, tell me the diagnosis. This is a typical lesion of Tinea corporis. Tinea corporis. This is a dermatophytic infection of skin caused by Trichomonas rubrum most commonly. Typical lesion is an annular erythematous plaque with vesicles, pustules and scaling at the margins. It is very, very, very itchy. Then this heals in the center and spreads peripherally. This is how a typical tinea looks like. Diagnosis is pretty straightforward. Otherwise, you can do a KOH scraping, which will show you hyphae. Diagnosis, griseofulvin, itraconazole, azole, terbinafine, everything works on this. You can give everything. So this is about Tinea corporis. If it would be involving the groin folds, then it would be Tinea cruris. If it was involving the scalp, Tinea capitis. Similarly, Tinea fasciae for the face, Tinea barbae for the beard, Tinea pedis for the feet, and Tinea manuum for the hand. Tinea, wow, there are so many Tineas. Tinea unguum for the nail. So these are all the different types of Tinea. Name totally depends on the site that it is involving. Most common organism causing all of these is Trichomonas rubrum. Treatment is oral as well as topical antifungals. Clear to everyone? So in this question, What is it saying? Which of these is false? So the diagnosis is Tinea corporis? Yes. Generally involves a non-hairy skin? Yes. Classical presentation is ring-like? Yes. Lesions spread inward with peripheral clearing? Wrong. They spread outwards with central clearing. So this is the false option. Correct, everyone? Good. Move on to the next. This is a tough one. You know it, you know it, you don't know it, you don't know it. Does this look like a microscope? No. Does this look like a Wood's lamp? No. Retinoscope, not for the eye, it is not looking at the eye. What does this look like? This looks like a mobile phone with the lens here. So this looks like something which has a lens which you put on the surface of the lesion and you watch on screen the magnified image. This is typically what a dermoscope is. Typically what a dermoscope is. This is could be a handheld instrument, could be something which is connected to a laptop or a desktop. The main purpose of this is surface magnification. You put it on the image here, you see it, it will magnify it 70 times, 100 times, 200 times, through which you see the finer aspects which otherwise are not visible to the naked eye or even a routine magnifying lens. So this can go up to 200 times the magnification. Up to 200x it can go. Extremely useful in clinical settings to make a diagnosis. Wood's lamp would be more of a bigger structure with tube lights and glass. Microscope, you all know, retinoscope is something like this. So this is a retinoscope, ophthalmoscope. This is different. Wood's lamp is different. This is a digital dermoscope. Clear to you? Good. Should we move to the next one? Yes. So this is question number 66. Please read it. Tell me what it is. A 26-year-old man from Bihar, juicy looking papules, hyperpigmented, normo-aesthetic, no nerve thickening, prolonged fever history is there. Very, very typical description. If I were to teach you this typical entity, this is exactly what I would have told you. This is how typical a question can be. And then you look at the image. What do you look in the image? You see these multiple skin colored nodules, predominantly in the perioral distribution, then on the forehead also. This person comes from Bihar. He has a history of prolonged fever in the childhood. What could be this history of fever in the childhood be for a person who is living in Bihar? It's an endemic area for this particular disorder, which is why this place of residence is mentioned, to give you the hint for this particular disorder. Most of my patients come from this particular belt of Bihar, Chhattisgarh, Jharkhand, because these are the endemic areas for this disorder, even Bengal. This is actually talking about Kala Azar. History of prolonged fever. Residents of Bihar is talking about Kala Azar. And sometime later in life, patient can have this hypersensitivity response. Which is your post-Kala Azar dermal leishmaniasis. Here you have these typical hyperpigmented lesions and these papules and nodules. Hyperpigmented macules are seen, then skin colored nodules are seen, then there is no loss of sensation or nerve thickening. This is to tell you that this is not leprosy. When you make a smear from the lesion, you see LD bodies. Then how do you treat it? You treat it with either amphotericin B or antimony, or the oral treatment is miltefosine. This is the oral treatment. So this is post-Kala Azar dermal leishmaniasis. Only thing that you have to do in this question is to differentiate it from leprosy. And to differentiate it from leprosy, they have already told you that this is normoaesthetic. And this is normoaesthetic and there are no nerve thickening. Because somebody who's coming from Bihar with such lesions, first differential is leprosy because that is more common. But if it is not leprosy, then the next thing that comes into mind is post-Kala Azar dermal leishmaniasis, especially when there is a history suggestive of Kala Azar. So it's a very typical question, very typical description, takes a long time to treat it, you have to give months of treatment, and still there is a chance of relapse. Post-Kala Azar dermal leishmaniasis. Had it been tuberculoid leprosy, would have been mostly a single lesion, not like this. Lepromatous leprosy would have glove stocking anesthesia, would have multiple nerves. HIV, no, it doesn't look like this. So clear, everybody? Good. We move on to the next question. What is the next question talking about? Next question is talking about a spot diagnosis. What do you see in the image here? Tell me, what do you see in the image? You see multiple coin-shaped or round patches of eczema. We have already studied it, right? Remember, in the initial questions there was a discussion on this. What is this called as? This is nomular dermatitis. This is nomular dermatitis. Typical clinical picture. Had this not been in the answer, option would have been discoid eczema. I would have marked discoid eczema as well. Generally seen in middle-aged men on the shins. Although this image is not there, but that is the typical of discoid eczema. Seborrheic dermatitis, what would this have had? This would have had yellow, greasy scales in the typical pattern. Contact dermatitis would give you history of dermatitis. It is not a morphological diagnosis. You cannot just see it and say it is contact dermatitis. Atopic dermatitis, again, not the typical clinical picture. Pneumolar dermatitis is the answer. Good. Moving on to the next question. Moving on to the next question.